right, good evening, everyone. It's my pleasure to welcome you to tonight's panel discussion on inclusive care, the hidden cost of anxiety and depression. I'm Sherry Kretschmer. I am the chair of the Professional Nursing Practice and Advocacy Cabinet, and I'm honored to help facilitate this important discussion. The program was thoughtfully developed by the entire cabinet, grounded in a shared recognition that disparities persist in how individuals experience and receive care for mental health conditions, particularly anxiety and depression. These disparities often go unseen, yet they carry a profound impact on patient outcomes, access to care, and the overall well-being of our community. Tonight's discussion brings together a diverse group of panelists who will share their insights, experience, and strategies for addressing these challenges. We hope this dialogue not only raises awareness, but also inspires action towards more compassionate and effective mental health care. So rather than reading the formal bios, I'd like to invite each of our panelists to briefly introduce themselves, share where they're joining us from, and tell us a bit about their work related to mental health. So let's begin with Joey Burke.
Good evening and welcome. I am glad to be here tonight. Appreciate the invitation. I am the nurse ethicist for the University of Kentucky. That is a unique position. I often have to explain the difference between a nurse ethicist and a nurse anesthetist. But anyway, I can't say that word. So my role as part of the nursing program and part of the team is really to bring ethics into the conversation. I am not the ethics police. I am, however, very concerned about vulnerable populations. And I think as we think about where that overlaps with depression and anxiety, those vulnerable populations can certainly be our patients and their families who are making really tough decisions, but it also is other members of our care team. So I think tonight we will really kind of dive into what does it mean to provide quality care for patients and also for each other.
Great, thank you. Thank you. Our next panelist is Stephen Summers.
Good evening, everyone. I am Stephen Summers, and I am joining you from my house in Versailles. This is actually where my wife works from home, so she has a nicer office with a nicer view than I do. But I am the Director of Pastoral Care for UK Healthcare, a role I've had since last September, so just a little over 9 months, closing in on 10 months. But I've been at UK Healthcare since 2011, most of that time spent working as a chaplain at UK Good Samaritan Hospital. And so excited to join the panel tonight. I think the main focus of our team always is around providing support, spiritual support, mental support, emotional support to all of our patients, families, and our staff throughout the entire hospital. So certainly see a lot of tie-ins with our topic for tonight. But yeah, very excited to be here and look forward to the discussion. Thanks.
Great, thank you. Thank you. Dr. Aubrey Jones.
Hi, thank you. I'm Aubrey Jones. I'm an assistant professor in the College of Social Work at UK, and I primarily work with postpartum individuals and families. I previously, as a social worker, worked with girls in juvenile detention and then went to work in a skilled nursing facility. So I've got quite a bit of understanding of depression and anxiety from both of those realms that actually helped inform my research and bring me to looking at postpartum depression and anxiety issues. And I focus a lot on rural communities as well.
Great, thank you. Nicole Capriel.
Hi, I'm Nicole Caparel. I'm Director of Care Coordination at University of Louisville Hospital. And thank you for having me tonight. I'm very excited to be a part of the panel. I think with my role, I tend to focus on, as a healthcare provider, being able to support our patients and my staff in making sure that our patients with depression and anxiety have access to care and that we're supporting the whole patient with the family as well to avoid our readmissions and honestly our healthcare costs.
Great. Thank you, Nicole. And last, I'd like to introduce Jennifer Topkin. Think I got it right? Yes. Go ahead and introduce yourself.
Hi there. Thanks for including me. I appreciate it. This is a passion of mine. I've been working in the population since 1996. When I first came to University of Louisville Hospital, I'm a LCSW with an undergraduate in psychology, concentration in social work. I moved here from New York, Buffalo, go Bills, to get my graduate degree. And that's when I fell in love with both U of L Hospital, where I currently am, and the population. The folks that I've worked with primarily is the severely mentally ill population. I was here and left inpatient to work in the community for about 17 years. I developed policy in Frankfurt, including Olmstead Act. I worked with length of stay in the state hospital, and then I worked in the community as the therapist and worked on the ACT team. I developed the Housing First ACT team here, and then I came back to U of L, and that's where I'd like to work with folks, both on the inpatient psychiatric, but throughout the entire medical hospital and the other hospitals within the U of L system.
Great. Thank you, Jennifer. Thank you for joining. Thank you all for your thoughtful introductions. And it's clear we have a wealth of experience and insight represented on this panel tonight. And I'm excited for the conversation ahead. So now that we've had a chance to get to know each of you, let's dive into the heart of tonight's discussion. And we begin by exploring some key questions around the disparities in care for anxiety and depression and how they show up in different settings, what barriers persist, and what strategies are making a difference. So let's start out with our first question, and it is, can you share any personal stories or examples that highlight the human impact of anxiety and depression beyond the statistics? So who would like to answer that question to get us started?
I'll take a stab at it since I went
All right.
first before, but we'll switch things up a little bit. So I think this is really going back to some of my roots. My first job out of college as an adult was in community mental health. So I'm going to age myself just a little bit. That was back in the 1900s. And in the early 90s, we really were seeing the advent of things like Prozac. And we were seeing medications come on the market. And so what we were having were conversations that included things like serotonin reuptake inhibitors. And it just really moved away from the idea that you needed to sit on the sofa and talk about your childhood. People were not benefiting from that in the numbers that needed the help. And so psychoanalysis just really was not accessible for many people and was not necessarily as effective as we would have liked. So as we began to see medications come on the scene, and Prozac was, one of the first ones, and then we started to see Wellbutrin and things that would target anxiety, it allowed us to shift the conversation. So it wasn't just a personal choice or a decision around, don't worry, be happy. Even if you knew the song, you couldn't just snap out of it, don't worry, be happy. There actually was something called a neurotransmitter that might have been influencing how you were perceiving the world. And maybe you don't really have much control over your neurotransmitters. And so I think as we started to see some options and people started to see depression being relieved and people able to function in ways that they thought perhaps was not accessible to them anymore, it really did change things. So we saw that also in children. We saw an understanding that actually children can have depression and anxiety, and it's not that they're a product of bad parenting. We saw something we heard, we were told it in fact could be a medical situation that required a very different intervention. So that's kind of how I got started and was in community mental health for about 12 years before I went to nursing school and then saw depression and anxiety show up as a bedside nurse in different ways there. So I'll stop there because I know we have more to discuss, but I think as a starting place.
Yeah. Nicole, did you want to share an example?
No, that's okay.
Okay. Stephen or Dr. Jones? Jennifer?
Sure.
Go
I'm
ahead.
sorry.
No,
I
go
go ahead. I was just kind of thinking of some things.
Yeah.
I think with both working inpatient as well as community mental health throughout the years, there's a different perspective when working with, folks. I think when I went from the hospital to the community mental health side, I did appreciate the fact that the deinstitutionalization was a thing. The Olmstead Act was very big in the 90s. It still is. But with that, with moving folks out of the state hospitals, out of the hospitals in general, their community was disrupted. And I do appreciate the fact that loneliness is a thing. A big part of what we saw when we moved folks out of the hospital into their own apartments was their isolation. And that really was a big deal for them. I think it was a factor that wasn't really recognized prior to that. There were people that would come back to the hospital wanting to be involuntarily committed. That was the terminology at that time. It was, that socialization, that's a real thing. That's a real factor. There were people that became more and more anxious, more and more depressed on top of their severe mental illness of, if they had schizophrenia, they just even more disorganized and detached and isolated. So that's one of the focuses that, it having friends, having social network, having adult day programs, having connections, and even just having someone to listen, just to listen and to be there for that support. I think that's a big deal. It's a big deal for all of us and for vulnerable populations as well.
Yeah, and you don't really see when you talk about the isolation, and you don't really see that in the data, right? When they don't really talk about that. It's so, yeah, great. Stephen, you were gonna say something.
Yes. When you asked the question, I found that I had several faces run through my mind. You talk
Uh-huh.
about the human impact of anxiety and depression, and the faces were of coworkers that are no longer coworkers anymore, people that were excellent nurses that I worked with for a number of years who, in the midst of and in the aftermath of COVID, uncertainty and anxiety they don't play nice together a lot. Living into so much of the uncertainty we did, especially around the pandemic, I watched as it exacerbated a lot of anxiety, and I watched as it exacerbated a lot of depression for people that I knew very well, and watched as they decided they couldn't do it anymore. Right. They had to get out of the system. And so, we see statistics like that all the time, right? And I'm sure we'll probably get into some of those as well, but those were very real to me. They weren't numbers, right? These were my friends and these were my colleagues. And so when you say human impact, that's immediately where my mind went of that was a lot more than just numbers. That was very real. Impacted me, impacted our health system, and certainly impacted the individuals I'm thinking about.
Yeah, great example. Dr. Jones, do you have anything you'd like to share?
Yeah, I would just want to say, like echoing Stephen about the colleagues, I think it's really easy as mental health professionals or nurses. I'm sure it's really easy to be able to recognize it in your patients, and it's a little bit harder to recognize it in ourselves and our colleagues. But I think what Stephen just brought up is so important, that our colleagues and ourselves also deal with this. One of the people that I thought about with this question was when I worked in a skilled nursing facility. I was the discharge social worker and primarily worked on our rehab unit. And so we had a woman come in who had been in a car accident, and she was having a really hard time getting out of bed, not because of the car accident, but I think it just ended up being a lot of anxiety about, what if I get hurt? I don't want to leave the safety of this skilled nursing facility. And our physical therapist didn't understand. He's like, she has to get up, she has to do this. And so as the social worker, I was trying to explain to him, like, well, I think she's dealing with some anxiety about this. Can you do physical therapy in her bed and start there, and then slowly try to think about how you can switch your care plan with her to slowly work her out of bed. And he was having a really hard time kind of grappling with that, but eventually, we sort of worked through it and worked it out. But we were also coming up against the pressure of the healthcare system, saying he was facing all the pressure of, if she does not get her hour of physical therapy 4 times a week or whatever it was, the insurance wasn't going to pay for her to stay in the skilled nursing facility. And I think that for me, it was this really eye-opening moment, how physical health and mental health are so interconnected, and the systems and some of the the access issues that play into that.
Great, thank you. Well, these were all great examples. And as the audience can hear, there's an array of different experiences here. And so it's just making this whole conversation more deep meaning. So thank you for sharing that stuff. Let's jump into access to care, because we know that there's barriers in being able to access mental health specifically. So can you share any barriers to accessing mental health care for individuals suffering from anxiety and depression? And how can those barriers be overcome in our current healthcare landscape environment?
I definitely think there's multiple layers of barriers. I think one is, just access to care, really. The lack of providers and facilities within our state. It's a shame. I think a lot of people who were able to provide that care and enjoyed providing that care have, suffered from depression themselves and anxiety and have decided to close practices, or, they've decided to not practice anymore within the hospital setting. I think the mental health crisis that we're having within the state of Kentucky right now, it's a vicious cycle, because we don't have the providers to provide the care that they need. And we continue to see them readmitted, and it just, a lot of them don't have health insurance. So we can't even adequately get them to, provider that can give them the adequate, care that they need. We have, we're looking at transportation issues. We have providers that might be able to see the patient, but the patient isn't able to access transportation to get there. They have no support. Once they do begin their therapy, they start feeling well and they come off their medications, or they stop going to their appointments, and, we start that cycle all over again. And I think the more they come to the hospital, and I hate to say this, I think the worse they're treated. I think their attention, they're labeled as attention seeking. They haven't, maybe their mental health diagnosis hasn't been, recognized within the inpatient setting, because they haven't shared that with us. And I really think that us as healthcare providers need to take time out of our schedule and really work with that patient. And I think that's one of my passions, working with case managers and my social workers, to remember that we only see a little bit of this patient's life, and to make sure that we're providing that extra time that is needed to make sure that they can get what they need once they discharge. I think people forget about that.
They do. Great. Thank you, Nicole. Who else would like to answer that question?
I'm not happy to chime in from a mental health standpoint. I think it goes across the spectrum of anybody, but stigma is still a big issue. And particularly for new moms, I see a lot of stigma around thinking that if you're suffering from depression or anxiety, you're not a good mom, or fear that your baby will be taken away from you, things like that. But then some of the other barriers that Nicole did a great job covering a lot of those barriers. I think mental health literacy is a big problem too, of just not even knowing that you are suffering from a mental health issue. And it's really hard to recognize in people because it is so individualized and different. And when you have a new baby, a lot of the screening questions for depression just sort of go hand in hand with having a new baby. Has your sleep changed? Has your eating changed? Has this or this changed? And it's like, well, yeah, I've been up all night with a newborn. And one of the things that we see with providers is having to help teach them to help differentiate between a new baby and anxiety. Like, are you up all night because you're watching the baby breathe? Or are you up all night because you're feeding the baby? And like really teasing that out. And then just for rural areas, and like this goes across Kentucky, right? Nicole said it, there's just not enough providers.
There's just not.
I think one of the things that we've run into at UK is that there is this perception, and it's most of the time correct, that if you want to see somebody or talk to somebody, you're going to wait a really long time. So for example, one of our benefits at UK is that each of our employees gets 5 free counseling sessions per year. And there was a time not long ago where if you went to sign up for one of those, it could be 2 to 3 months out, right? And that's a long wait when you've decided you're ready to reach out for help. Through a lot of different efforts, that time has shrunk way down now, thankfully, which is good. But if even now, as I'm talking to staff and they're struggling and I remind them of this benefit, they're like, I can't call there. It's going to be 2 or 3 months, right? It's still out there that it takes such a long time that people don't even bother to check or don't even bother to call. So in that way, the problem kind of builds on itself, even though we've made a lot of strides to improve. We're not communicating that well enough to where people know that, and it changes behavior. So that's something we've kind of run into, and something that I hear pretty consistently is that I'm not even going to try because it's not even worth the effort. It's going to take too long.
And to build on that, Stephen, I think a lot of insurance companies now make it very difficult to have patients obtain mental health care. A lot of therapists out there now that are in private practice don't accept health insurances, and they don't accept the health insurance because the insurance companies make it so difficult to receive payment that it's just not worth the provider's time at that point. And I think, with patients, a lot of them don't even realize that if they are able to locate a private paid provider, that they can make arrangements with their insurance company to submit the paperwork themselves, the claim. Of course, a lot of providers want you to pay that, fee up front, and a lot of our patient population don't have the means to do that. But the ones that do don't even realize that they can, submit that claim on their own to the insurance company. They can do that ahead of time before they even start seeing that therapist, to have it, almost like single case agreements, that you submit for reimbursement through the insurance company, because someone who's in network with your insurance company has a year wait.
I think it's interesting too that, when we talk about things like having 5 free visits available for employees, and that's an employee benefit, it's interesting to me because we would not ever set any kind of limits on the number of cardiology appointments you could have, or infectious disease consults. But what if I have something that requires more than whatever arbitrary number you set? Are we so concerned that people are going to abuse the privilege of seeing someone in mental health that we have to cap them with this arbitrary number and make then the process more cumbersome to get more because somehow they don't deserve 7 or 8 or 9 visits? It's very intriguing to me that we've sort of picked mental health as that thing for which we will ration you because you might not really need it. Is that the thought? So it's just, even within our own healthcare system, there is some disparity there. Like, we don't set those limits elsewhere, but we do for mental health.
Exactly. Jennifer, would you like to add to the conversation?
Sure. I'm going to kind of go a different path, if that's okay. Some of the access to care barriers that, when that question was posed, went to the symptomatology of a true depression and failure to thrive. I've worked with very, very ill folks, and I've seen a lot of pretty depressed folks. Access to care, when we were going out into the community, I would do therapy literally on the floor while the client, the patient, was in their bed. They were, at that point where, for an involuntary, it wasn't quite meeting the criteria. But again, having that support without judgment, but not really even having the energy to get up and get in the car and go to a therapist or anything like that. So I think going to the clients that we served in the community was huge. That, I think saved lives, to be honest. And I think that there needs to be more of that. I know that there's dangers with doing that. There are a lot of situations I probably shouldn't have been in, put myself in, but I'm here. So, but I think it's scary for people. People are scared of the liability. They're scared to go into, maybe not so great neighborhoods, substance going on and whatnot, but just kind of meeting that patient or that client where they are. And a lot of time it might help the next time, and it might get them through a rough patch. So I think that's where my mind went when we were talking about access. I was just thinking about their inability to really even get out the door.
Yeah, there is a question in the chat from Melissa that says, does the 988 phone line serve as an impactful bridge in providing access to mental health care for people?
I mean, I think it does. We give that number out as a resource. It's not, if you call it, they're not going to come and pick you up. I think that's a misunderstanding of some folks, that if they call it, something's going to happen. Here in Jefferson County with 7 county services, we do have the deflection team, which they are embedded in 7 counties, and they're sometimes a peer. It, is kind of called a warm line, where folks can call that when they're in crisis or when they need support. And I've talked to many patients that come here that have been brought in by the deflection team. They're non-law enforcement. They are supportive. They're not always clinical in nature. They're more of a peer support. But when they call that, they're not automatically committed to a hospital. So I think that gives some safety to the person that needs that support. And a lot of times it gives them what they need until they can get to that next, level to get them through the night.
Yep, you're right. All right, well then let's jump into the third question. We talked about the barriers to access to care. So let's talk about the cost, because that in itself can be a barrier. And how does the cost associated with anxiety and depression affect both the patient and the healthcare system as a whole?
I'll go ahead and comment. I think as a healthcare system as a whole, I think, we definitely feel, the impact of that. I think a lot of it is our patients continue to come back. They have increased hospitalizations, increased ED visits. They have, increased outpatient visits and medication costs that a lot of times they're not able to afford. And as a healthcare system, we're providing that for them in hopes that it does cut down on, the increased ED visits. I think for a patient that it's, extremely difficult for them to go into medical debt for the increased visits that, they don't have insurance or they can't afford their copays or, just different things like that. I think it's, it's cyclic, right? And I think it is, as a healthcare system, we're picking up a lot of that cost.
And a lot of times they can't afford the medication.
Correct.
Right.
Right.
And right.
And I know our social services, if they're uninsured, we're paying for that medication for, their 30 days. And a lot of times the patients are aware of that and they come back, and we do, another admission or we do an ED visit and, the social workers are, arranging to have their, medications paid for again for 30 days in hopes to stop that cycle.
It's certainly expensive from an untreated standpoint as well. Like for untreated postpartum depression and anxiety, I think there was a study that I was reading that it cost about $14 billion across 5 years to the society as a whole. And that was calculated in terms of lost wages, repeat visits to the doctor's office, because with untreated postpartum depression and anxiety, we often see overutilization of the healthcare system, like going to the pediatrician more often because of anxiety reasons. But with untreated depression, you might see someone neglecting a medical issue for a long time, and then it becomes more costly once they finally go to the doctor because we waited so long. But with postpartum depression, I think about not just the economic impact, but the family and society impact. So with untreated postpartum depression and anxiety, you run the risk of poor attachment between mom and baby, which can lead to future behavioral health issues, cognitive delays, all sorts of delays for the child, which can then be costly down the road for that child and that family.
Very much so. Very much.
I
Joey?
think, yeah, two things to think about. Cost. We know that it is real. It is about money, and it also is a metaphor. So thinking first in terms of the real cost, we're talking not just about the price of medications or hospitalization or some of the newer therapies that are on the market now, being able to access those, what are becoming more traditional paths to therapy, just how to advocate with your insurance company to get the prior authorizations for some of those treatments. So money plays into it, but I think what we're really talking about is the cost, which the time. It is the cost of not having access to interventions and what that does for your employment and potentially losing your job. So the price becomes something so much bigger than just access to healthcare, because without it, the dominoes start to fall. And that's when you really begin to see job security is vulnerable, family security is vulnerable, parenting is vulnerable, relationships are vulnerable. So that's really, I think, what we're getting at too, is that bigger cost.
Yeah, exactly. Jennifer, go ahead.
Sure. To kind of piggyback on that, I can't help but go to the housing situation, that one leads to another, housing, and then, with that, there's all sorts of trauma and, hospitalizations for, other injuries, assaults, thing. It just kind of branches into, the crime, the jail system, prison system, all sorts of things that, come from that. So it is a large issue. Yeah.
It really is. Because it starts to like fingers, right? It just kind of starts spreading and it's might not present as anxiety and depression, but it's a result anxiety and depression. Yep. Well, let's talk about the role of the healthcare provider, because as Nicole said earlier, there's not enough in the state, but the ones we have, how can they better support our patients, especially in terms of reducing the stigma that's related around these conditions?
I can kind of start there if that's all right.
Right ahead.
I think, as Dr. Jones was talking about, stigmas are still just such a very big part of everything that we're talking about. And one of the things that I think can be the most impactful is, I think people just really need to be heard. And that comes out of my own background as a chaplain, right? People need to be heard, and people need to have their experiences valued and believed. I think people benefit from having a safe space. And I don't know that there are a lot of safe spaces where people feel comfortable to talk about a lot of those things. So a lot of times that happens in a hospital or happens in a healthcare appointment where they will open up, and how we respond as caregivers, I think, can set them on one of a few different courses. But if we take that moment and we handle that well, and we provide a safe space, and we truly listen and value what they're saying and make them feel believed and heard, I think it can set them on a better course and start to kind of push back against some of those stigmas. I'm someone you can talk to and say, I've had thoughts of killing myself, and I'm not going to get scared. I'm not going to run out of the room, right? I'm going to sit here and we're going to talk about it. We're going to have an honest conversation about it, and I'm going to hear your story and hear your experience. I think that can change things, and that can really allow people to feel more comfortable opening up.
Great. Other panelists?
I think with that, I hate to say normalizing, but normalizing, we all go through things, and without disclosing too much to patients, but identifying with, where they are, and, it's okay, that's normal. And sometimes that, just saying that is helpful to kind of let the guard down a little bit, and know that you're in their corner, and just, being present and listening. So I think that education to healthcare professionals, I think, is always a good thing. Understanding diagnosis, because it's complicated. There are certain behaviors or actions that go with different diagnoses when they're unmedicated or untreated, and it's not personal. It's part of the symptoms and the treatment that's needed, and not being judgy, just being supportive, and maybe not being worried about saying the wrong thing. I know that has been a concern that I've heard over the years with students and field practicum, social work students, is that I don't want to say the wrong thing. I don't want to put something in their head. So, just being supportive and being true, being genuine, that goes a long way.
Yeah. Dr. Jones, you were gonna say something.
Yeah, I was just gonna say empathy and normalizing it to the best of your ability, and whatever your comfort level is of sharing. When I was dealing with really bad postpartum anxiety with my firstborn child, I'll never forget that nurse and doctor, because I was so scared, and I had tried everything. I had the internet had given me all the ideas, like use essential oils, do more yoga, because I was so afraid to admit that I had something like anxiety or depression. And so I was going in with the nurse and she said, yeah, I dealt with that too. And it's pretty common. And then the doctor was like, yeah, we have 5 kids. My wife dealt with that with almost every single one of our kids. And they were just so nonchalant about it. And it felt like this big weight lifted off of my shoulders to know that I wasn't the only person who had ever experienced this. And I was witnessing 2 people in front of me who had gone through it and had gotten through it. And they were just really empathetic about it. And to Jennifer's point about like not being afraid to say the wrong thing. I worked in suicide intervention for a long time. And that's like, that can be really scary to say, are you thinking of killing yourself or are you harming yourself? But it's also really important to just be direct about it because it does help alleviate some of that stigma, but also patients can tell when you're squeamish about talking about something. So if you're showing that you're confident, like if you are the calm pilot in that situation, they're going to be and more likely to talk to you about it.
Great, great. So now let's talk about, we're going to take it up a notch and we're going to go to policy. So let's talk about what policy changes would you recommend improving the care and support of individuals with anxiety and depression?
I would like to lobby for the insurance companies to mandate for mental health coverage and not have a limit on the visits. I think that would be one of my, biggest pushes.
One of the policy places that I can see some real improvement perhaps needs to be made is around the culture of calling in. And in nurses, they really cannot call in, and that is just part of the profession. But I think we have to make space for taking care of each other and figure out how to move the needle a little bit. So our call-in policies, for example, are pretty restrictive, but when people need to take care of their own needs, they need to be able to take care of their own needs, and they need a manager who will support their call in so that they can go see a counselor, go see a doctor. Nursing schedules often are such that you are working when the doctor's office is open. And so we have to be able to recognize that taking care of each other is a priority. And so we need to do some careful look at what we are setting as our call-in policy, our absentee policy. What if you have a patient, a nurse, a provider of any kind, really, who is chronically late? Let's do some assessment around what is this really about before we jump right to punitive. Let's figure out if there's not something else going on here and try to take care of our colleagues.
Yep. Any other comments around policy?
Well, I just have to say.
Okay, Jennifer, go right ahead.
So it's been my kind of thing for, I don't know, about 30 years now, that unfortunately, I don't think Kentucky has the adequate resources to serve folks with severe mental illnesses and long-term care and just in general. But where I see it right now at U of L is in placements. About 30 years ago, I found Ohio as a resource, and we have utilized that resource quite a bit. But digging a little deeper with that, I think the reason Ohio has been such a great resource for us, and I don't really want to say it that loud because I'm afraid it's going to dry up, is that in Ohio they have more resources. They have better Medicaid reimbursement. They appear to have better understanding in general of dementia, of depression, anxiety, of schizophrenia, and even substance use disorder and long-term effects of that. So I would love for some of that to kind of trickle to Kentucky. I've been asking for it for about 30 years, so it should be time for that to happen. But that's been my go-to for many, many years, to have more resources here in Kentucky, because it's terrible. It separates families, even though Cincinnati is only an hour away. It sounds so far away. Families are just devastated when they have to send their loved one to another state. So that's my thing for policy.
Great, great. No, thank you for sharing. All right, let's get into our last question for the night, and that's innovative solutions. So are there any innovative approaches or programs that have been successful in addressing the hidden cost of anxiety and depression? And Jennifer, you talked about just not so much innovative, but just the amount of effort and resources put into the programs in Ohio. But is there anything setting out there that's innovative on the horizon?
So I think there's a few things throughout, that I've seen firsthand here that I think throughout the years, we used to have specialized personal care homes. They were on the grounds of the state hospitals, which was frowned upon. It was a stigma. However, there were wonderful things attached to that. It was a sense of family. I worked at one of the specialized personal care homes. It was an entire community. Some of these folks with severe mental illness, they have nobody. They have no one. That sense of community, that sense of family. And that happened back in the day. That was part of the specialized personal care homes. And where everybody was kind of accepted, and I brought my kids to work with me at times. They wrapped Christmas presents. They met the residents. It was all one many years ago, but those of course have closed down, and the folks have gone to their own apartments in the communities. And, that was helpful for some, not for all. I think that's needed. I think the personal care homes in the state of Kentucky, there's some good, but a lot of bad. So, but it's better than the streets, I'm not sure. So I think, the specialized personal care homes that work with the medical component as well as the psychiatric, dealing with the colostomy, working with the psychiatric part, not being afraid of medical and psychiatric, and having stable housing with care, love, and support. To me, that worked. That was a wonderful thing that has gone away. I do think that with that, the community work, the integration with the intensive community treatment team, that definitely works for some folks as well, where you meet them where they are. I've met people, under a viaduct, and I've met with them to get them their, medications and collaborate that way with other professionals. So I think that's great, but there's just not enough of those services.
And Sherry, I'll tag on to that. And, Jennifer's not going to toot her own horn, but I am very proud to be, a part of the program that she has developed at university that provides our current social workers an LCS supervision program. This track allows, I think it supports our patients, because it requires our social workers to provide 200 hours of therapeutic counseling at the bedside in order for them to be able to sit for their LCSW. And Jennifer has started that program and is our, LCSW supervisor. I believe we have 6 social workers within our department that are under supervision right now that are getting ready to sit for their LCSW. And I think that offers our patients a little more of an elevation, support that we're able to provide within our department.
Yeah, that's great. Thank you, Jennifer, for doing that. Thank you, Nicole, for sharing. Other innovative solutions that we've seen around the treatment of depression and anxiety.
I theoretically really like the medical home model. I say theoretically because I don't actually know much data wise or personally how it works, but became familiar when I was living in Tennessee. And for rural communities, I think it's a really great resource because transportation and access are such an issue. And for anybody really, there's nothing more exhausting than having to take multiple days off work to go to your dentist or your primary care, etc. And to have it all in one space, I think is really smart. And I don't know that it's necessarily innovative since it's already around, but I would love to see more of those popping up, especially as rural hospitals are closing and we've got maternity care deserts. If we could have more of these in rural areas, that make it easier, and partnering with social workers, psychiatrists, and other mental health professionals to also be housed there so that it becomes this one-stop stop. And, a lot of anxiety and depression might be exacerbated by basic life necessities that are missing that a social worker can help address. You can help get access to right then and there.
Yeah, great. All right. Well, we've got some questions in the chat and comments. I want to share that with the group. I think this question is for Jennifer. It says, how does an individual contact the deflection team?
So in Jefferson County, deflection is within the Louisville Metro. So if there is a call to the 911 or the 988, it's routed to the deflection team members. Initially, that was only Monday through Friday, kind of 9 to 5, but the hours have been expanded, and the deflection peer usually is able to connect with a person on the phone, and sometimes they just go out. They actually bring the patients here to the hospital, so it's not just a phone call either. They will go out and check on the person, and then they can talk to them, and if they need to, or if they want to come in, they'll bring them into the hospital.
Okay, thank you. Cherie Robinson, she appreciated a statement that we talked about. She says, along with being a public health nurse who works as a home visitor for the Kentucky HANDS program for many years and worked in the local mental health hospital for many years as my second job, normalizing is part of the training for the healthcare worker on how to communicate with patients and families. Thanks for mentioning this. Next question, I believe this is from Jennifer. The video mentions the pros for access to service of telehealth, yet it may not expose the individual to triggers which help gets to the mental needs. What are your thoughts about this statement made in the video?
I kind of have a mixed review of telehealth, although I think that there are some patients that benefit from telehealth. It's wonderful. There is a large population of very severely mentally ill patients that absolutely do not. And those patients are extraordinarily paranoid. They're afraid of technology, computers, and won't even go into a room where there's a computer. So I think that's that missing part. But there are definitely, with telehealth, positives. I don't want to negate that, but with telehealth, there are things that are missed, and I hate to be graphic, but, part of symptomatology with depression is maybe ADLs are being missed. If someone stops showering, that's not really picked up when you're doing a telehealth. And that is a sign, an initial sign, and that's part of therapy. And, that's something that, it might not sound nice, but that is something that, if you're meeting with someone face to face, you can say, when was the last time you were able to take a shower, and kind of address it at that point. So I think that's where my mind went when I heard that, and I do agree with that. But I do think that telehealth is helpful for folks that, have other barriers as far as transportation and other things like that. But I definitely agree that things do get missed.
All right. Now we have a question. What are your thoughts about psychedelics with regard to policy and efficacy?
When I was watching the documentary, I got to the psychedelic part, and I have always been a little bit skeptical of it, but I have some friends who are like clinical social workers, and they talk about, there's more evidence coming out. And I was just having a conversation about it the other night with two social work friends, and they were talking about like how it can be used and why. And it's interesting. I think it's interesting. I am really skittish about it because I do worry that it could, like they talked about in the documentary, become this thing of like, I'm just going to go take ketamine at the doctor's office, and you're not actually addressing the root cause. But I also can see how it could be helpful based on the descriptions that I have heard from people who have done psychedelics, or my friend's conversations the other night about how it might be used to help process. But I have a lot of reservations about it.
I definitely
we all
need to be monitored. I think it's one of those drugs out there that allow you to numb that pain and numb that feeling. And I think, you really have to work closely with a provider.
Joey, go ahead. You were gonna.
Yeah, well, whether we're talking about psychedelics, or one of the things that we're hearing more information about is electric shock therapy. There are other therapies that are being used that may have a squeamish factor to it, but I want to encourage us to be nurses and to to do the questioning and what does the evidence-based research tell us, and not to jump to a conclusion without having done a full assessment. That's kind of what we're trained to do, is do some assessment. So while psychedelics, may have this sort of magic mushroom 60s vibe, there's more to it than that now. As with electroshock therapy, there's some magnetic therapy that I don't understand, but people are using it, they're getting results. There are tools, and I think we have to consider what are the tools that we have to work with, and not everything is a nail just because you have hammers. You have to have a great matchup with the need and the resources and the available tools. So what that might look like is not a one-stop shop of what everything's going to work for everybody. It's not. There are things that will work for some people. There's things that will not work for others. We know that about every other aspect of medicine. So let's use our nursing core as we assess what's available and what's helpful.
Exactly. With that, this part of the program will pause and see if the audience has any questions they'd like to unmute and ask the panelists. All right, not hearing anything and not seeing any new questions in the chat. I saw Melissa's hand go up. Melissa, go right ahead.
Yeah, I was wondering, is there a current role or a potential role that's being studied for artificial intelligence in helping to manage anxiety and depression, whether it be in the clinical setting or the home setting?
I'm not aware of anything. I'm not sure if any of the other panelists are.
Thank you.
I do know that there's kind of a hot button issue with therapy, artificial intelligence therapy apps, with some concerns with that. I don't know enough about.
Oh, okay. I was wondering what was the concern, or what have you been hearing about?
So I think with the social work ethics, that has been a real big focus as far as artificial intelligence and the practice changing of therapy in general, that there's bots that, do therapy, and the implications of that it's scripted to a point, and is there a human component to that? If it's a bot. And I think that that's kind of the rub and the controversy. Also, if someone has any suicidal, homicidal ideation, where is that taken when there's bot therapy going on? So I think it's just the beginning, and there more to come on that. But I do know it's on the radar for therapy and with the social work ethics board. So yeah.
Okay. It looks like, I think this is Jennifer who's got her hand up. Jennifer, you have a question?
Yes. So they talked about in the video how much primary care is ordering medications, but then there is this disconnect that people are not getting therapy. And as we've talked about in this panel and on the video, it mentioned that this mental health care is a layered approach. There's so many things that need to go into it. Do you all see that is truly happening? There's so much medication being doled out, and not enough resources, but kind of what are your all's thoughts on that? Do you feel like, especially since the video also mentioned that some SSRIs lose efficacy after a year? So kind of what are your thoughts about that?
I definitely see an increase with PCPs writing the medication with our patients. And I think a lot of times it's because they're seeing therapists and not MDs. And so they continue working with their therapist, but they're in need of medication. So the therapist, refers them to their PCP, and their PCP is comfortable writing those. But I think it's very important for the PCP to, have a relationship with that therapist as well.
Do you think then that the therapists are directing more of the dosage and which meds versus people going to psychiatry for that?
No, I think it's the PCPs doing that.
I see it every day in EPS whenever I work in emergency psychiatric services, patients that are in crisis, and we ask where are you currently getting your medication prescribed, and they say PC, primary care provider, and the doses and the medications are just not correct, and it does more harm. I understand that there's lack of resources, but mental health is complicated and shouldn't be taken lightly. And I don't mean to sound rude when I say that, but there might be someone that's trying to help and say, sure, I'll write you a script for that, but it might open up a whole can of worms. So we see the effects of that in the hospital, and sometimes it makes a patient more suicidal.
Yes. Do you think that there's a stigma with going to a psychiatrist versus
Yeah.
going to your primary?
Absolutely. Absolutely. And that's another thing that I hear. It's like, oh, I don't have a psychiatrist. I just go to my primary care physician. So I'm fine. Everything's okay. So there's that stigma. Absolutely.
Yep. Great questions. Great questions. I
Oh.
see
From a postpartum perspective, I see a lot of providers that just
you.
offer medication. Like ideally, I think a lot of the providers are aware that medication in tandem with therapy is really your best option. But specific to postpartum, there's not enough providers that are trained in postpartum mental health and the intricacies of that. And so I do see a lot more women that I work with specifically get on medication because there's not enough resources in terms of therapy for them. And some of that is wait lists, not enough providers, and cost. Really.
So that's kind of the default, the first where they go to. I see Ellen has her hand up. Ellen, do you have a question for the panelists? Ellen? All right, we'll go to Melissa. Melissa's got her hand up.
So, with the assumption that mental health challenges like anxiety and depression are a global problem, I'm imagining that there are other countries that may have even lower resources than Kentucky. What are some other countries or other cultures doing to help manage the mental health challenges? And is there an increasing role of the nutritionist or something used in different countries that's been helpful? I mean, is there any sort of data or research or that you can share on that? I guess I'm wondering, there's more than one way to manage this issue, even with low resources. So what else can you share with us? Because I think the financial landscape is going to potentially tighten up. And
Yeah.
so not having anything, we don't want that to stand in the way of helping. So what do we know that you can share that's been tried maybe in other cultures and other countries?
I could answer this in like a really specific way, I guess, related to postpartum. Really only in my experience and research knowledge is that social support is probably one of the biggest protective factors for depression, but specifically postpartum depression. And so we do see in countries that have lower finances and whatnot, that their social support system is so much stronger and they have lower rates of postpartum depression. I run a 4th trimester support group with UK, and that's one of the things that the women tell us every week is I need a village, and I need a village that I don't have to pay for, because right now in the US it's daycare, it's a cleaning person, it's a nanny, and you're paying for all of that. And in other countries that's not necessarily the case. In some countries, like I had a colleague who was from Korea, and she was absolutely appalled that I left the house at 3 weeks postpartum. And she said, why are you not in bed? Why are people not bringing you food? You shouldn't even be out of bed yet. And we don't do that well, I think, in the United States. And social support it's not easy, but it's certainly easier than other solutions.
Yep.
And I think on that note, the family dynamics, and I'm not well versed in other countries, but just what I've heard historically, the family unit stays together longer, elderly, parents age, with their children. It's kind of a family thing. So, I mean, to me, again, support is huge and shouldn't be minimized. That's kind of magical.
Great.
Yeah, I honestly don't think that a lot of other countries have the rate of depression and anxiety that we do here in the States. And I think it's our lifestyle,
I finally got unmuted.
Oh, Ellen, great. Ellen, this will be our last question for the night. Ellen, thank you.
It took me forever to get unmuted. I don't really have a question. I just wanted to thank Joey so much for talking about the importance of doing that careful assessment in getting a detailed history before jumping to a conclusion. And these panelists have been awesome, a great offering, but I just want to particularly thank Joey.
Okay, Joey, you're muted.
Thank you. That's very kind. I appreciate very much the opportunity to have this conversation because I think it is so important because for us as providers, for the people that we come in contact every day, I think one of the statistics that we saw from the video was like 1 in 5 adults in America experience some sort of mental illness. So that can be varying degrees of things, but that's a lot of people. That's a lot of our patients, our coworkers, our attending physicians, as we think about the people that we engage with every day and we're trying to figure out and navigate really tough situations, recognizing that depression, anxiety may be playing a role in what we're experiencing in the moment. And assessing what then do I do, which is not a knee-jerk reaction. If somebody's getting salty with us, we don't get salty back. Or if somebody's withdrawing, we see that a lot with families who are forced with making really complex medical decisions, they withdraw. And so we meet them where they are. And so assessing what is really going on here, I think we got to stay close to our roots and that's always where to begin.
And just to add on to that, Joey, is that I think when we look at that, we're focusing on a lot of our adult population, and our pediatric population is really neglected. And we have to think about if the parents and grandparents and the adults taking care of these children are suffering from depression and anxiety, are they really supporting these children? What are we setting these pediatric patients up for as well in the future? Unfortunately, I really unless there's a really big change soon, I think we're going to have even much larger crisis in the incoming years.
Yep, agreed. All right. Well, let's close this wonderful panelist discussion. It was thoughtful, it was engaging, and your insights, all of the panelists, what you brought to this discussion from clinical experience to systemic challenges to opportunities for change. Each of you brought a valuable perception to this conversation. So as we bring this discussion to a close, I do want to take a moment again to thank each of our panelists for your thoughtful contribution and what you were able to provide to this important conversation this evening. So before we wrap up completely, I'd like to share a few upcoming opportunities through the Kentucky Nurses Association that may be of interest. July 17th, that will be the election forum that will be Meet the Candidates. And this is a chance to hear directly from those running for leadership roles within KNA. And then August the 1st through the 15th is when we will have our actual elections, and your voice matters. So don't forget to cast your vote during this election window. On September the 5th will be our 5K run. Come and join us in fun and energizing event that supports nursing wellness and community engagement. And then September the 9th is our Kentucky Nurses Foundation One Day of Giving, and a meaningful opportunity to support the Kentucky Nurses Foundation and its mission to advance nursing through education, research, and leadership. We hope to see you at one, if not all of these events. And thank you again for being part of tonight's program and for your continued commitment to provide and advance equitable, compassionate care for all. Thank you.